Good morning. It is a real pleasure to be here today to have a discussion about pregnancy and anticoagulation, practical considerations. Thank you to Ethicare for sponsoring this lecture. Firstly, by way of introduction, pregnant women have a 4 to 5 times higher risk of developing thrombosis compared with non-pregnant women of the same age, with an estimated incidence of thrombosis of approximately 1 to 2 per 1,000 pregnancies. A hypercoagulable state, venous stasis, and vascular damage at delivery all contribute to this increased risk. Roughly half of pregnancy-related thrombotic episodes occur during pregnancy, and the other half during the 6-week postpartum period. In the developed world, thrombosis is the direct leading cause of maternal mortality, while in South Africa, the major cause of maternal death continues to be infection-related. What is of concern is that the rates of pulmonary embolism in South Africa have not changed in the past 3 trienniums. The first topic I'd like to discuss is anticoagulant choices in pregnancy. Low molecular weight heparins are the first choice in pregnancy based on available safety and efficacy data. Unfractionated heparin has a similar fetal safety profile, but requires PGT monitoring and is associated with an increased risk of complications such as HIT and osteoporotic fracture. Warfarin, as this audience well knows, is associated with teratogenicity, CNS abnormalities, miscarriages, and stillbirths, and should be avoided in pregnancy. It is, however, safe to use in breastfeeding moms. DOACs are not recommended during pregnancy and breastfeeding. ISTH even more so advised on the use of anticoagulants other than DOACs in women who are trying to fall pregnant. Nonetheless, exposure to DOACs in early pregnancy has not been found to be associated with a significantly increased risk of embryopathy. For these reasons, I will focus on low molecular weight heparins. In women using DOACs or warfarin, a change to low molecular weight heparin is advised at the time of a positive pregnancy test. It is important to counsel women on the side effects of low molecular weight heparins. Bruising is common in pregnant patients. Skin reactions can also occur. These are mainly type 4 delayed hypersensitivity reactions at the injection site. This image, with consent from the patient, shows erythematous lesions at the injection sites, which were tender. These skin reactions may improve with a switch to another class of low molecular weight heparin. Fondaparinux can be considered if there's cross-reactivity with low molecular weight heparins. Data about the use of fondaparinux in pregnancy is limited, and its use in the first trimester is not recommended. HIT is a very rare complication of low molecular weight heparins, and the incidence is very low in pregnancy. In South Africa, the choice of low molecular weight heparins include enoxaparin and nadroparin. Experience with bemiparin in pregnancy is limited, and fraxiparin has been discontinued. For treatment of VTE in pregnancy, a weight-based adjusted scheme is initially recommended, with subsequent adjustments according to the peak anti-10A level. The twice-daily approach is a more rational approach pharmacokinetically. When it comes to duration of anticoagulation, many current guidelines do not provide clear guidance on the duration in women who experience a thrombosis in pregnancy. In this large retrospective cohort study, the cumulative incidence of recurrent VTE was significantly higher in women with an unprovoked compared with a pregnancy or postpartum related VTE at 10.4 and 5.8% respectively. More recently, the Rett investigators reported a 2-year VTE recurrence rate of 3.3% for women whose initial event was pregnancy or postpartum associated. These data suggest that limited duration anticoagulation may be appropriate for most women with a pregnancy-related thrombosis after close follow-up and personalized assessment of risk factors. Guidelines currently recommend anticoagulation for at least 6 weeks postpartum for a minimum total duration of therapy of 3 months. Moving on to a discussion about VTE prevention in the antepartum period, guidelines have suggested various approaches. These include an intermediate or anti-10A guided dose-adjusted dose for high-risk pregnancies, and for intermediate-risk pregnancies, these include a low prophylactic dose or clinical monitoring. optimal low molecular weight heparin dose for women with a prior VTE is currently being investigated in the ongoing high-low study. These results will provide us with high-quality data on the management of high-risk women in pregnancy. The increased risk of VTE is similar across trimesters, and as such, low molecular weight heparin prophylaxis should be initiated as soon as a pregnancy test is positive. With regards to postpartum prophylaxis, the optimal duration remains undetermined. The risk of VTE is highest within the first 2 weeks postpartum, and therefore a 10-day course of thromboprophylaxis is recommended for intermediate risk women. When the risk in pregnancy is considered high, guidelines suggest that low molecular weight heparin should be prescribed for 6 weeks postpartum. Monitoring of anti-10A activity is performed to ensure adequate low molecular weight heparin dosing, as during pregnancy, the pharmacodynamics of low molecular weight heparin are altered as a result of the increased volume of distribution and enhanced renal clearance. This is demonstrated in the figure in a study by Bailey et al., who reported that 16% required dose adjustments in the second trimester and a further 31% in the third trimester in order to achieve a target anti-10A of 0.2 to 0.6. Current guidelines suggest not to monitor anti-10A levels to guide dosing of low molecular weight heparin. This is because studies to date have not demonstrated an improvement in efficacy and safety outcomes with regular anti-10A monitoring. Practically, anti-10A monitoring also has several limitations. These assays are relatively expensive, they're not routinely available, and the timing of the assay is important for accurate interpretation. The expert opinion, however, is to monitor anti-10A levels in high-risk pregnant women, regardless of weight or renal function, until further guidance from large clinical trials evaluating clinical outcomes is available. Women should be instructed to inject in the morning so that they reach a 3 to 4 hour peak level of anti-10A for blood sampling during office hours. Anti-10A levels can be performed 1 week after commencement of treatment and thereafter monthly or per trimester during pregnancy. The last topic I'd like to touch on is some practical considerations around delivery. Management of delivery is best considered by a multidisciplinary team in order to minimize the risks of maternal hemorrhage, epidural hematoma, and thrombosis. In women at very high risk, scheduled delivery is preferable in order to minimize the duration of time without anticoagulation. There are increasing safety reports of unplanned deliveries, where women are instructed to immediately stop low molecular weight heparin upon the first signs of labor. The disadvantages of an unplanned delivery are the increased risk of bleeding and limited access to neuroaxial analgesia or anesthesia. The last injection before a scheduled induction of labor or elective Caesar with low molecular weight heparin in the therapeutic dose should be 24 hours, whereas a 12-hour window is sufficient with a prophylactic dose. Considering the risk of spinal or epidural hematomas, these time intervals also apply. Post-delivery, low molecular weight heparin should be started at least 6 hours after removal of the catheter. The cannula should not be removed within 12 hours of the most recent injection. Low molecular weight heparin should be delayed at least 24 hours if there is blood in the needle or catheter during insertion. Neurological monitoring is mandatory for a minimum of 12 hours and ideally for 72 hours after neuroaxial blockade. If the time interval is too short and an emergency Caesar occurs, patients will have to undergo a general anesthetic. In the postpartum period, anticoagulation should be restarted 6 to 12 hours after delivery, but this period should be longer if hemostasis is not adequate. The reported rates of major bleeding with low molecular weight heparins in the postpartum period are 2% for major bleeding, and for clinically relevant non-major bleeding, the rates are 6%. For postpartum thromboprophylaxis, continuation with low molecular weight heparin is the most practical option at a non-pregnant dose. In women who will continue anticoagulation long-term and who plan to breastfeed, low molecular weight heparin should be restarted and warfarin therapy should be delayed post-delivery, and this is to avoid double anticoagulation immediately after delivery. Low molecular weight heparins can be discontinued as soon as the INR is therapeutic. So this brings me to the end of this presentation. In conclusion, low molecular weight heparins are safe and effective in pregnancy for the prevention and treatment of venous thromboembolism. There are still important gaps, and high-quality research in this area should be a priority. Therefore, the recommended approach is to individually risk assess each patient and engage in shared decision-making. Management of delivery needs a multidisciplinary approach in order to decide on the most ideal delivery plan. Neuroaxial analgesia or anesthesia can be given in most patients, provided time intervals are respected. Finally, it is very important that treating doctors counsel all young women with an episode of thrombosis about risk factors, contraception, and future pregnancies. I'm very grateful for your attention. Thank you.
While we're waiting for questions, may I ask you on the place of filters, IVC filters in the peripartum management of women at risk of venous thromboembolism?
IVC filters have been used in pregnancy since as early as the 1980s, but experience is still, and evidence is still limited with regards to IVC filters. They are associated with their complications, but of course they do have a role, particularly where anticoagulation is contraindicated and therefore can be used in pregnancy.
I think I agree with you. I think over the last 35 years, I cannot remember a case that we have actually used one, especially if we do use in pregnancy, we should be aware to take it out in order to prevent later complications. My second question would be, how would you deal with pregnant women with COVID-19 who is on the ward or in the ICU? Would you give different anticoagulation compared to the pregnant women without COVID?
So in our experience, we have been doing a personalized risk assessment on these women who present with COVID-19. Owing to the infection and the prolonged hospital admission that's been associated with it, we have been risk stratifying them as intermediate risk, and we have been giving them prophylaxis as intermediate risk candidates would receive. Those, however, who develop thrombosis are being treated as a VTE in pregnancy. So we have not been treating them differently. I'm not sure what your experience is.
Right.
Benjamin, may I also ask a question to Elise?
Sure.
Sylvia?
Hi, Sylvia.
Well, first a comment, thank you so much for your brilliant presentation. With a short comment, I would like to extend an additional thank you, because VKAs and DOACs, as you said, are not guideline supported. However, we see that in real world, and that has been reflected in Garfield VTE. We saw in some countries that although not supported by guidelines, the pregnant patients were treated with VKAs and DOACs. I think you put us on the right track back. And my tricky question goes in the direction already addressed by Benjamin, and that's the worst case. How would you treat a patient who might have been vaccinated during pregnancy, which is not a contraindication, but develops the worst case, the VITT, thrombocytopenia and thrombosis? What would be your modality of choice as an anticoagulant?
So fortunately, we have not seen those cases. The predominant vaccines that we are using in South Africa are the Johnson & Johnson and the Pfizer, which have very low rates of it. But in accordance with the guidelines, provided that the woman is post the first trimester, we would recommend fondaparinux as our first line treatment at a therapeutic dose in those patients.
Why only in the first trimester? I would go for the entire pregnancy, because fondaparinux has been shown.
So just because of the risk of embryopathy with fondaparinux in the first trimester, we are reluctant to use it in the first trimester. But so beyond the first trimester, I would recommend fondaparinux.
But beyond, okay.
And beyond, and yes.
I completely understand. Thank you so much.
Yes. But the question is the duration of therapy.
Absolutely.
There are questions from the audience. Normal mild drop in pregnancy. Would you do platelet counts, and how often with unfractionated heparin and with low molecular weight heparin?
So with low molecular weight heparin, the recommendation is actually not to routinely do platelet counts because yes, the platelet count is expected to drop with pregnancy progression and because the risk of hit is so low. Where the risk of hit is higher, such as in the case of using unfractionated heparin, which is very rarely used today because of the inconvenience associated with it, regular platelet monitoring would be recommended at least per trimester.
Of course, there is another question of how do you manage a patient with mechanical valves or women with permanent atrial fibrillation, pregnant women?
So firstly, with regards to mechanical valves, we have published guidelines in the SAMJ, which specifically refer to the management of patients with mechanical valves, where low molecular weight heparin is the preferred drug to vitamin K antagonists such as warfarin. In the case of women with mechanical valves, because the risk of clotting is higher, we aim for an anti-10A level of 1 to 1.2, and anti-10A monitoring is done in these patients on a weekly basis. Their delivery is according to a multidiscipline routine. So that's with regards to mechanical valves. With regards to patients with atrial fibrillation, there is a lot of debate as to whether or not they should receive therapeutic or prophylactic doses of anticoagulation. European guidelines and the American guidelines differ. And our approach is to, once again, individually risk assess each patient, taking into account the underlying cause for the atrial fibrillation and whether or not it's associated with valvular heart disease, whether or not it's been associated with subsequent cerebrovascular incidents, and to decide on each individual patient basis whether or not to treat them with prophylactic or therapeutic low molecular weight heparin during pregnancy.
Right. Okay. I think in the sake of time, we will stop here and have some break.
Thank you very much.
Thank you.